Hello, everybody. Welcome back to the Incubator Podcast. We are back today for a special interview. Daphna is in the studio with me. Daphna, good morning.
Good morning, everybody.
We are joined today by Dr. Alex Kemper. Alex, welcome to the podcast.
Thank you. So excited to be here. And Daphna, Ben, I know we're going to have a great conversation this morning.
I think
Yeah.
so too. For people who shamefully do not know who you are, um, you are the Division Chief of Primary Care Pediatrics at Nationwide Children's Hospital, Nationwide Foundation Chair in Innovative Pediatric Care, and Professor of Pediatrics at the Ohio State University College of Medicine. You serve as, I would say, the newly minted Editor in Chief of Pediatrics. Is that correct?
That is 100% correct.
Congratulations on that. You
Thank you.
completed your pediatric residency at Duke University, followed by a combined fellowship training in health services research and medical informatics with residency training in preventive medicine at the University of North Carolina. Your research focuses on preventive services in the primary care practice setting. You're a former member of the U.S. Preventive Services Task Force, and you've served as chair of the Evidence Review Group for the Advisory Committee on Heritable Disorders in Newborns and Children. You also served as the chair of the subcommittee that revised the American Academy of Pediatric guidelines for the management of neonatal hyperbilirubinemia, which is the one of the reasons why we would like to speak with you today. Um, I guess the question that a good place for us to start, Alex, is um, we hyperbilirubinemia is mentioned in these new 22 guidelines. You're right; it remains one of the most common conditions managed in the newborn period. It is something that medical students are trained on. Kernicterus remains rare but continues to be reported. What is the motivation to go after this 2004 guideline and come up with a revision? What was the incentive to even begin the project?
Well, I think there's several answers to that question. One is just as policy that the American Academy of Pediatrics has is that it regularly revises all of its guidelines, looking for the best available evidence and making sure that the guidance that it's giving to clinicians is still the right thing to do. And so this was a planned revision, but I think it was also an opportunity to clarify a lot of questions. So there were questions that came up when we began looking at the previous guidelines about things like the role of routine screening of bilirubin before babies get discharged. There were questions around how to best use the risk-based nomogram that was in previous versions. And then there's always been questions about the threshold for phototherapy and exchange transfusion. And so this revision gave us an opportunity to think more about those kinds of questions. And then as a general pediatrician, one of my goals was to try to simplify the guidelines as best we can. That helps avoid medical error, makes the guidelines easier to follow, makes things more transparent. And as part of the simplification process, I wanted to make sure that we were being appropriately deferential to the clinicians who are taking care of the babies so that when the evidence wasn't very strong, that we were clear about where options could be made using things like informed decision making between the clinician and the families. So that's sort of the thinking that went into the revision.
Yeah, and I think that the new guidelines were welcomed by the community. I think that it's been quite impressive to see how quickly these were implemented by clinicians, both pediatricians and neonatologists. And I believe that one of the most striking change from the 2004 guideline has been that the thresholds for treatment of hyperbilirubinemia were raised, I would say significantly. And what was striking in the substantiation of that change in the 2022 guidelines were that it seemed that you guys were quoting a lot of evidence that said we've realized that we really don't need to intervene until these levels are quite high, and that this even with that the risks of um, severe neurological morbidities like kernicterus are we're still far away from these. And so it was quite a surprise to hear that we had a lot of room to go up on these thresholds that we previously did not realize.
That's exactly right. And figuring out where to put the thresholds really consumed, I would say, like, years of conversation, and the reason I say that is we certainly know, that there are levels of hazardous hyperbilirubinemia that are associated with developing, kernicterus, right? But where exactly is that threshold where the 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 risk benefit of treatment sort of switches, where does it really make sense to begin treatment? And when you think about the issues at hand, right? You have babies of varying gestational age, um, babies with different risk factors for developing hyperbilirubinemia or having what we refer to in the document as hyperbilirubinemia neurotoxicity risk factors. There are a lot of variables in here. And so it was really hard to figure out exactly where to draw the line, right? Like ideally, you would want to do some sort of risk based analysis at each threshold with looking at all the variables that we talked about. Well, that's obviously not possible, right? So we had to make informed decisions based on the best available evidence. And I'll tell you that there were some people in the committee who thought that we ought to go higher. And um, we were able to look at some data. For example, we had access to data from Kaiser Permanente, Northern California, so we could see and model out what might happen as you change the threshold. So um, the thresholds went up by 1 or 2 milligrams per deciliter, sort of depending upon gestational age and risk factors and those kinds of things. But that's about the order of magnitude of the change. But what I can tell you is that's a substantial drop in the babies that need phototherapy. Um, but there was a lot of discussion and a lot of thought that went into that.
I love that. I'm tickled to hear that, like, higher thresholds were being considered because I think this was, a stark change and a little bit of a challenge, for our community, and our unit. Well, I mean, we changed practice right away, but it was kind of like, this is a baby I normally would have started phototherapy on, and we're not doing it. And so, I know you've gotten a lot of feedback. You get a lot of questions and emails. How do you feel like the community has received the new thresholds, and have they been able to really introduce it into practice?
You know, I I was nervous as the guidelines came out because there were a lot of changes, right? We got rid of the risk-based nomogram, which some people refer to as the Butani nomogram. We changed the thresholds. We introduced some new terms. What I can tell you is because we had this, 8-year period in developing the guidelines, is that we were able to work with a lot of partners and really understand what it would take to um, put things into practice. We were also able to work with representatives from a lot of the electronic medical record vendors, right, to help them put in the new thresholds as well after the guidelines came out. And then tied to this whole thing, and I had to give the American Academy of Pediatrics a lot of credit for this, is they put together a quality improvement project that involved, I don't know what the numbers are, but it was like scores of well baby nurseries across the country to be able to test the implementation. And I'm going to say this with like absolutely no science, and I'm going to be 100% full of hubris. But the guidelines were like seem to be taken up really quickly, like much faster than I would have guessed. Um, and what I can tell you too is that there have been studies looking at whether or not there have been changes in the rates of kernicterus or hazardous hyperbilirubinemia, very high levels of hyperbilirubinemia, and that simply has not occurred. So you know, I think we got it right. I know that there will be another committee looking at the guideline, another, what is it, 4 years or something like that, and they'll be able to clarify and plug some holes that I think remain in the current document. But I'm pretty happy with how it played out. Now, I am so biased, right? But I think I think it worked well.
I love that. And now you've mentioned the risk stratification quite a number of times, and even though that risk nomogram is absent from these guidelines, I'll say I think a lot more time was spent on kind of this risk stratification or really outlining not just which babies are at risk because of, innate characteristics of the baby, but also these neurotoxicity factors. And I think it sheds a new light on that, like, not all hyperbilirubinemia is the same. And I think we recognize that, but we were treating babies pretty much the same. Can you talk a little bit about the kind of this emphasis on identifying babies at risk?
Yeah, I think you captured it well, so I'm not sure how much I'm gonna have to add to that, but, in the guideline, we outline sort of 2 buckets of risk. There's the, bucket of risk related to just developing hyperbilirubinemia, in the first place, and then another bucket of what we refer to as hyperbilirubinemia neurotoxicity risk factors, and these are risk factors that lower your threshold for developing kernicterus at the same level of, bilirubin as, babies who didn't have those, risk factors. So the risk factors for hyperbilirubinemia, for these hyperbilirubinemia neurotoxicity risk factors, it's such a long thing to say, I, like, stumble over it every time I say it, include things like younger gestational age, having a low, albumin, having a hemolytic condition, um, uh, uh having sepsis or otherwise, being clinically, unstable. And I'll tell you, this is an example of where we tried to defer things to clinicians. We probably spent, I don't even know how many months trying to define what clinical instability was before we realized that this is the kind of thing that the pediatricians recognize all the time. And it was sort of a fool's errand to be able to specify clinical instability um, perfectly, right? Like you both are neonatologists, right? You know when a baby is unstable. We don't You don't need us to tell you when that is. Um, but those are things that lower the threshold for treatment. Um, I would like to go back to the risk nomogram because I do get a lot of questions about why that's not in there anymore. And a lot of work went into developing that risk-based nomogram by, Dr. Vinny Bhutani, who is, really a internationally renowned neonatologist at, Stanford, who was on our, subcommittee and who had been on the previous bilirubin, guidelines subcommittees, and so this was a decision that we made, along with him, um, uh and there are a couple of reasons why we decided to move away from it. Um, One is just in terms of clinical practice, we noticed that people got confused between the risk-based nomogram and whether or not the baby needed to be treated, right? So the bilirubin would be plotted on the risk-based nomogram, and if they, were at high risk, um, there were many infants who were started on phototherapy, even though when you marched that risk over to the treatment, curve, they didn't actually need it. So it was a source of confusion and a source of error. The other thing is that the, risk-based nomogram was around predicting who was gonna be above the 95th percentile. But the 95th percentile, it's hard to know how that maps directly to the risk of developing kernicterus, right? So just because you're above the 95th percentile, it's not the same as risk for, developing, kernicterus. So, this is an example, as I mentioned before, of trying to simplify things, by removing that and decreasing the, error, and just being clearer about risk, as you see in the, figures that are in the revised, document.
Yeah, I think that was such an interesting approach because it feels like the new guidelines are definitely in line with precision medicine. I feel like we have to this risk-based assessment of every infant based on their risk factors, based on their gestational age, which was also a new twist to the approach of risk assessment. And yet, one of the first few paragraphs, or maybe one of the first few sentences of the paper, does mention how prevalent hyperbilirubinemia is. Like, if I the first sentence actually, more than 80% of newborn infants will have some degree of jaundice. And to me, it felt like of all the things we care for, maybe that's not the one that needs precision medicine. Maybe that's the one that we could be a bit more generalist. So how did you strike that balance between trying to be as individualized as possible for these different categories, all the while dealing with one of the few pathologies that affect most of our newborns?
Yeah, that's such a great question. So it's abundantly clear that most newborns are going to get some degree of jaundice, but not all newborns need to get phototherapy, and certainly very few of them need an exchange transfusion or that sort of more aggressive care. So the issue became, how do you separate these things, right? How do you take this like vast pool of newborns who don't need to be exposed to phototherapy and figure out like who really does need to get therapy, um, while not dividing the pot up so much so that the babies who really require treatment don't get it. So, you know, phototherapy um, can be really disruptive for families, right? It can prolong the birth hospitalization or cause readmission, right? Nobody wants that. It can disrupt bonding. It can make feeding more challenging. There's lots of downsides to phototherapy. I should say it as an aside, we did look at other longer term risks of phototherapy, like the risk of developing cancer, which we didn't find evidence to support as long as, you know, your phototherapy system is well calibrated. Um, so in general, phototherapy is safe, but boy, it can be really disruptive to families when it's applied and not needed. So, that was the philosophy that we went, into it with. Ben, does that answer your question?
It does, and it actually leads me to the next topic that I wanted to discuss with you. At some point in the paper you write that phototherapy, although highly effective, is not benign. I thought this was one of the biggest reframing of management of hyperbilirubinemia that this paper provided, and looking at phototherapy not as a benign intervention. um, it's that it should be viewed as a medical intervention with potential both benefits and harm, because I feel like, and I include myself in this category, we too often are kind of flippant about duration of phototherapy, exposure to phototherapy. Be like, oh, one more day, you know? And one of the reasons for this reframing is also very powerful, because I feel like for us as practitioners, and I include you in this category, Alex, but we want to see the number go down. We want to see the number go down to whatever threshold some attending in residency drilled into you, and you feel like that's the safe number. But in the new guideline, it mentions our goal is to get away from the number that is synonymous with exchange transfusion, not some arbitrary value that you feel comfortable with. Can you tell us a little bit more? I mean, you worked on this paper with the team for 8 years. How long?
8 long years. Um, so I can tell you that the issue of when to stop phototherapy, that was probably like another 2-year discussion. I'm laughing, but I think it probably really was. Um, because, um really, what you wanna do when you stop phototherapy is minimize the risk of rebound, right? So you just wanna do it and you wanna be done, right? And, while we were working on this, there were 2 different, risk-based calculators that were, developed. One of them was actually, um the sort of the twinkle for it came from the work that we were doing, trying to figure out, like, what that right number was. And so, if you stop 2 milligrams per deciliter below the level at which, the phototherapy was started, your risk of rebound, uh, hyperbilirubinemia is really low, and that's why we put it there. But if you look in the document, it refers to some other risk-based calculators to figure out, when to stop. I'll tell you, I one of the common questions that I get is, about, um, babies who are getting phototherapy and, you know, they look like $1,000,000, but the levels just are going down, right? They can't really reach these levels that we talked about, and Again, I point people to the documents and the risk calculators so that they can make informed decisions with the families about when to stop the phototherapy. But I also remind people when I get this question, I probably get this question like once a month, um, is um, if you really can't drive the bilirubin levels down to these, numbers where you can stop, you have to think about whether or not there's something else going on. Is there persistent hemolysis that you're not recognizing? Would be one of the things that I would think about. But um, the other thing that can be challenging about the numbers that we put in the guideline in terms of when to stop is that if you start phototherapy at a really young age, right? Like while they're still in the birth hospitalization, it can be really hard to get down to those thresholds. So again, I point people to the other risk-based calculators and the need to have informed decision and close monitoring for those babies that started early. If you have to start phototherapy very early in the birth hospitalization, you really have to think about what's going on to cause that. But assuming that everything is okay, then I think you just have to look and see where things are and make a decision and make sure that there's good follow-up if you do stop phototherapy.
And I love that you've talked about the risks of phototherapy, because I think we saw this in training. We still have some colleagues who say, yeah, I'll leave the kid on, I just want to get it down. I don't want to have to deal with it later. And I think you highlighted some of the risks. I think one that goes underappreciated is that we think it's no big deal, but when parents see that their baby needs any kind of treatment, it is like for some parents catastrophic. And I think we don't recognize that what happens in the room after we leave, even when we've left them in the newborn nursery. Your thoughts about that?
Yeah, sort of example of that I think about a lot is for the issue of whether or not you're debating continuing phototherapy or starting phototherapy during the birth hospitalization.
Mhm.
If the numbers look ominous, they're getting towards the treatment. So we discourage subthreshold phototherapy. But I think it's fair to say that there are some families that would rather do anything than to have to be readmitted, right? And for them, if the trend line looks like, they're gonna be a winner, so to speak, that they're gonna cross, that for them, it might make sense. There other families that just wanna get out of Dodge, right? And they're willing to take the risk of, readmission, and I think, as long as you have good follow-up, that's the key. I should say, and I usually sort of start off saying this, is that one of the secrets of management of hyperbilirubinemia is making sure that you have good, close follow-up,
Mhm.
that you all in the newborn nursery or in the NICU are communicating with whoever's gonna see the family, post-discharge, that, things are in place for testing if it needs to be, tested, that there be clear communication because, you know, that's where people get into trouble. It's
Yeah.
not a like, "Oh, maybe we should start, maybe we shouldn't," kind of like borderline edge cases. It's the families that, get lost in the shuffle.
Yeah. I wanna come back to that. I have a question about KAS8,
Oh,
but but,
now I had to look it up because
no,
who
no, no,
remembers my number?
well, I'll review it, but, I wanted to just, you had mentioned, evaluating for malignancy related to phototherapy, and maybe you can speak a little bit to the link to or association with epilepsy.
Yeah, so there was just one study that suggested a very small increased risk in, the risk of epilepsy among boys, and, I'm really not sure why there was that sex difference, and again, the risk itself was really low. So when you look at these studies evaluating the association between, phototherapy and longer term harms, you have to think about confounding and other issues that might come into play. Even the degree to which having the high bilirubin level itself might be playing into things, and not the phototherapy itself. And as we talked about, babies are complicated and they have a million different risks going on. So I can't comment on the sort of underlying reason why there's been this association, and I look forward to more studies being done in the area. At the time that we began, there was more concern about the risk of cancer, but subsequent larger studies, I should say, haven't found that association. So I think by and large, as long as we're using phototherapy appropriately, and I'm going to go back and say again, as long make sure your phototherapy units are calibrated to the um, right frequency and intensity. Then I think as long as you're using it for the right purpose, I wouldn't worry about these longer term um, medical risks.
And the paper mentions this difficulty in correlating accurately hyperbilirubinemia and neurodevelopmental issues, and how it's already poorly correlated in terms of, we know there probably is an association, but to what degree, at what thresholds, we don't really know. And so the papers do so very eloquently of cautioning the clinicians about trying to intervene for that particular outcome, specifically understanding that this outcome is not well defined yet. Can you tell us, how do you make somehow a recommendation without, when the physiology behind it is not super well established? I thought you guys did that very well, but I'm sure it was a lot of thoughts and pains and anguish.
I appreciate your kind words, and I appreciate your recognition of the pain and the anguish. So I think what you're referring to is the bind or bilirubin-induced neurologic dysfunction. Bind itself is really confusing when you go and look at the literature, because there was something called the bind score that was related to predicting the future risk of developing neurologic problems for babies who were exposed to high levels of bilirubin. But bind also refers to these more subtle effects that could potentially be caused by bilirubin. The epidemiology is complex, right? So knowing exactly whether or not these more subtle neurologic issues were caused by more modest elevations in bilirubin is difficult to determine. But what I can tell you is, from looking at the various treatment studies, is we didn't find any uh, direct linkage between treatment, so phototherapy or exchange transfusion, with changes in these more subtle neurologic things. So I think it's important to remember that we're treating to prevent kernicterus, um, but there's an absence of data showing that the treatment, phototherapy, exchange infusions, whatever, um, decreases the risk of more subtle neurologic problems. And so um, that's why we had to focus in terms of the things that we were trying to prevent. And we did try to, in the document, explain this nuance.
Love that. We haven't spoken a lot about monitoring. We've talked a lot about starting phototherapy, and I recognize that there was a whole section dedicated to transcutaneous measurements. And was that? And again, over 8 years, practice has changed quite a bit in regards to that. Was that an intentional direction for clinicians, or was it because of kind of practice shift in the community?
Uh, uh, so that sort of brings up a couple of different questions that I want to address. So one is just the use of transcutaneous bilirubin testing in the first place. I can tell you, I oversee a large outpatient network, and all of our clinics have transcutaneous bilirubin devices, and it's fantastic because we can. Um, just right there, check the bilirubin level, and if something needs to be done, we don't have to worry about following up with the family. That being said, the transcutaneous bilirubin devices, have a range of error, right? So if you're within, a few points of needing phototherapy, you do need to um, get a serum bilirubin, right? So it's the serum bilirubin that makes all the decisions around treatment. One of the questions that's come up is once you've begun a baby on phototherapy, right? So you've, gotten a TSB, it's above the phototherapy threshold, you've begun phototherapy. Can you um, switch back and use your transcutaneous device? And there are little skin coverings that some companies make to protect the skin so that they say that the transcutaneous devices still work. Or if you're able to correlate your transcutaneous device with the bilirubin level, the total serum bilirubin level, can you just get away um, with that?
Yeah,
Um,
so the idea being not to expose a specific area of the skin so that could be used as your test site.
exactly,
Okay.
exactly. It's like a little patch. I can't remember. I think they're bilirubin clips is one of the names for them. But you protect the skin, and then that's your little target for the transcutaneous device. At the time that we were working on the guidelines, there are a lot of questions about whether or not you could really go back and use the transcutaneous devices. And so, out of an abundance of caution, we said, once you're monitoring somebody for treatment and they're getting phototherapy, just use total serum bilirubin levels. I mean, the reality is that most of the babies are going to be getting blood draws now and then anyway. Um, and that, it was okay to go back to transcutaneous bilirubin after, 24 hours or so of, being removed from, phototherapy. There have been other studies that have come out since the, guideline was released around the safety and effectiveness of using transcutaneous bilirubin, measurements, after phototherapy has started. And, I don't wanna steal that from the people that are gonna write the next guidelines, so they can figure that out. But, you're exactly right that the science, continues to, evolve, as do the devices.
Are you already excluding yourself from the writing of the next guidelines? Is that what
I
we just
wouldn't
heard?
I wouldn't wanna, rob someone from no, I would be happy to be involved. The academy convenes these, subcommittees. I I was brought in, um, because I'm a general pediatrician and they wanted to make sure that there's a general pediatrician. There are other general pediatricians in the room, but somebody who is a general pediatrician who was not so enmeshed in the bilirubin world
Uh,
that I could provide the, sort of perspective of, somebody who's sort of at arm's length from previous decisions that had been made, and so that's how I got involved. But the people that were on the subcommittee are just top-notch people, and I learned so much from them, but, it did, it did take a while.
I wanted to ask that my follow-up question that I had before. We've talked a little bit about stopping phototherapy and the follow-up, but I really appreciated this guideline 8 that if appropriate follow-up cannot be arranged for an infant, recommended to have that follow-up. Bilirubin discharge may be delayed, and I think it's such a nuanced but like very important point in today's medicine. I actually think follow-up is actually getting harder, not easier for our families. They're being switched on insurance every few days. The pediatricians have less office availability. They're not testing in-house anymore, a lot of pediatricians, so then they have to go to the lab. And then the converse of that is managing insurance, for an extra day's stay. Um, I think this does offer some protection for those babies where you're really worried about the social risk. And I think you alluded to this, like, we do a pretty good job of managing bilirubin when it's kind of right in front of us, but when they go out there in the world and nobody's following it, that's really where we see babies, get into trouble.
That's 100% correct, and you just need to work with families and talk with them. It's a sad fact, but I agree with you that this issue of follow-up after discharge can be complicated, for, some families because of the system that we have, in place. Um in interest of full disclosure, I don't do expert witness stuff, right? I don't, I get contacted by lawyers fairly frequently around bilirubin issues, to see if I would be willing to serve as, provide expert witness guidance. And I just don't do that, but when they send me the email and they lay out the case, you'd be surprised how often it is the exact kind of thing that you were talking about, where the family didn't understand about the importance of follow-up, or the receiving pediatrician didn't understand that, they needed to get a repeat, bilirubin level. And so it is an area that's fraught with danger.
Alex, I wanted to ask you a little bit about what has been the follow up, the response since the publication of the guideline. Obviously, we've talked about these thresholds being slightly higher since the 2022 publication, and obviously leaving a little bit less room, I guess, between treatment of hyperbilirubinemia and exchange transfusion. We've mentioned that the guidelines have been received very well and that they've done well. Are you getting is there any systematic review of data that has been done that confirm that the guidelines are doing well? Are there any anecdotal reports that you're getting? And do you think, I kind of know the answer to this, but I just want you to have the opportunity to share that. And my follow-up question is, do you think that because of this feedback, the levels might be pushed even further up the next time?
So, what a great question. And I can tell you that there's still a lot of room between the thresholds that we picked and the risk of developing kernicterus. But I say that with caution because I don't want people to like let their guard down, because the bilirubin levels can go up quickly in some infants. And at some point, you do have to draw the line. One of the things that we didn't talk about that's not in the guidelines, that has come up that's relevant to this, that I just want to make sure that I put out there, is that there's also a lot of variability, from lab to lab around, TSB. So we act like when we get a total serum bilirubin level back that this is like, the exact value, and it's being handed down from Mount Sinai, and that this is like the God's truth. But there is a huge amount of variability from lab to lab. And so, when setting the threshold, you also have to think about that laboratory variation, and maybe what you're getting isn't exactly right. And so that was built, into things as well. So in the United States, we don't have a kernicterus registry, right? So there's no place where all cases get reported. But I mentioned before the American Academy of Pediatrics did that large quality improvement network. There have been some other secondary analyses that have been done from, other data sources like the Pediatric Health Information System, which is a data set put together by the, freestanding children's hospitals, that have not found an increased risk of hazardous, hyperbilirubinemia, since the new guidelines have come out. Fortunately, kernicterus is a rare event, but there's been no signal of increased, kernicterus. We have a safe margin in terms of, where the phototherapy and exchange transfusion thresholds have been set. I personally, it's always dangerous when you predict the future, right? Like, it's kind of a fool's errand. But uh, I suspect that the curves will probably stay where they are for those reasons, even the small increase, the bump that we put really had a dramatic increase on the number of babies that are getting phototherapy. So, I mean, who knows what the future is going to hold, but I suspect that the curves are probably going to stay where they are for the laboratory issues and the overall safety that we talked about.
Thank you. We've learned a lot about the guidelines, but we wanted also to inquire a little bit more with your expertise on, you know, the 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 production of guidelines. And we've mentioned a few times about specifically how long this guideline took for something that, again, I think the community overall feels pretty comfortable with. And so I wonder, what were the sticking points? What were the kind of hardest things to navigate? And what are your recommendations for people who are undertaking the work of creating, clinical practice guidelines?
There were a lot of, challenges during while we were writing it. I think that the biggest issue is the one that we've spent the most time talking about in terms of where do you put the thresholds and how do you balance, avoiding unnecessary treatment while, not causing, risk, and the removal of the risk-based nomograms. That all took a lot of time. There was also, a lot of discussion around issues like, uh G6PD deficiency and how to consider, G6PD, deficiency. Um, and in terms of, future recommendations for guidelines in general, I think that it's important to be clear about what you want the, outcomes to be at the end. We were lucky in terms of we were very clear that we wanted to simplify things and decrease unnecessary treatment. I think that, uh, neonatal hyperbilirubinemia brings up so many issues in terms of, having a terrible outcome if you, don't treat things appropriately, combined with, gaps in the evidence around where things are safe and where they're not safe. So I just think that that's what took most of the time, and the members of the committee were very, very thoughtful about, how to put things together. Um I have been involved in putting together a lot of other clinical practice guidelines, and this was really the one that took by far the longest. Oh, yeah, there was this other thing that happened while we were working on it, which you might have read about in the papers, this pandemic.
Uh, I don't know what I don't I
If
don't know
you
what you're referring to.
if you could remember that at all. So that certainly didn't help things either, but I I thought that was really important, and there were many diverging opinions that we have consensus at the end of the day, and I think it led to a better, product. So, most clinical guidelines, fortunately, will not take 8 years, but, there was a lot of nuance to work through. One of the lessons that I learned in putting this together, which I wish I had thought about earlier on. So when I first began, I thought, "Oh, this is gonna be easy because the guidelines are working and it's not really gonna take very much to clean things up." And then, of course, I got into the nuances we've talked about for the last, half hour or so. Um I wish that we had included more parents up front. So as we completed the clinical practice guideline, I did actually reach out to parents and also advocates in um, related to kernicterus to get their feedback, and uh, they're, they were very grateful for us putting in the routine bilirubin screen prior to, discharge, because that's something that they had been advocating for a long time. But it gave me a different perspective on, um, the importance of shared decision making, and it also raised, very complicated questions around, G6PD deficiency, given that, there's no easy way to test for, G6PD deficiency when you would really like to know it, which is, right there when the baby is in front of you. So, the recommendation that I would give my, like, self if I could travel back in time would be to have, some of these parents serve on the committee, from the start. And I can tell you that I've had lots of conversations with leadership at the, AAP, and that's something that they're gonna be routinely doing moving forward. So I think that's great
Yeah, not just for this particular set of guidelines, but for,
for
an
everything.
approach. Yeah,
Yeah.
yeah. I think that's definitely the one of the biggest innovations in our collective opinion about, this century of guidelines and approach to neonatal care. Um Alex, thank you very much. I was going to bring up the issue of having families, and I think it's critical that, as you mentioned, families were involved in the peer review process, but like you said, even involving them from the onset could be even more beneficial. So we really appreciate that perspective. We want to congratulate you again on an amazing paper, 8 years worth of work. I mean, I don't think people realize. Um, it's more than most of us train for.
Yeah.
So
My hair went gray in the process.
so that's definitely impressive, and we will link to again to the guideline in the episode show notes. Thank you again for spending this time with us today, and again, congratulations and best of luck on everything else.
Thank you for your kind words, Ben and Daphne, and thank you for inviting me to your forum.
Thank
A
you.
pleasure.